Hi, everyone. It's so great to be here with everybody. A huge thank you to the Samira Foundation, Michael, and everybody. This is amazing. Joining me is Dr. Veronica Cipriani and Dr. Carolyn Goldschmidt. I'm super excited to talk about autoimmune encephalitis and stiff person syndrome. I am the founder and CEO of the Stiff Person Syndrome Research Foundation, so I'm really, really thrilled to be here. And a patient, yes. Sometimes I forget. So let's start with some introductions, and with those, I would love to hear what motivates each of you to be involved with these rare diseases.
You don't need the mic, or?
Yeah, you can use it too. I think we're going to have to pass it around a little bit.
That
Okay.
has a switch. Please turn it on.
Okay, thank you. Maybe. Yeah, I don't want the mud to your water over. So I'm Veronica Cipriani. Thank you so much for having me here. I'm so excited to be here to talk about autoimmune encephalitis because, as we were talking about earlier, it's a rare condition, and so it's hard to find support groups or places where patients can come together and learn and talk about their experiences. So I really appreciate the opportunity to be here. Like I was saying before in the main session, neurologists in general really like to solve puzzles and mysteries, and I think that's kind of what drew me towards rare diseases. I think, all of us have a story of a patient that we've seen in the hospital, especially, I'll talk more about autoimmune encephalitis that is incredibly sick, someone who's oftentimes in the prime of their lives, young, and goes to being in the hospital, having seizures, sometimes being intubated in an ICU for a long period of time, and that kind of inspires you to say, what could we be doing for these patients? How can we, what could we have done differently? Could this have been diagnosed earlier so it wouldn't get to this point? I think is really important, and really seeing how patients can thrive and go back to their lives after treatment has been just really humbling, and that is, I think, the main reason why I like to focus on some of these rare diseases.
Hi, I'm Carolyn Goldschmidt. I'm also a neuroimmunologist. I definitely got into neuroimmunology in general because I did grow up with a family member with multiple sclerosis, so I was very familiar with it my whole life, and then obviously went through the whole medical education thing. And then I really like immunology in general and neurology. And I always joke that, I like neurology because we're very cerebral. So same thing, we like to solve puzzles. And with the rare diseases especially, it's really nice to be able to focus on this small group of rare but very interesting, disorders that we do have. Especially in neurology, it's kind of rare to have these very effective disease-modifying therapies for a lot of these diseases, where in a lot of the other neurologic subspecialties, we don't have that advancement right now. So that is very satisfying, again, to see these patients who can be extremely sick and then walk out of the hospital later. When I'm talking to med students about it too, I'm always like, it's all the cool stuff academically. It's just these very interesting presentations that can be very satisfying to treat.
Thank you both. And as a patient, I'm super grateful for you all, being interested and involved in treating rare diseases, and all the other docs out there who are. So it's great. So thank you both. So Dr. Cipriani, how would you define autoimmune encephalitis?
So the word encephalitis is encephalo is brain, and itis is inflammation. So it's inflammation of the brain. And depending on what that inflammation happens, it can cause a variety of different symptoms. But in a classical autoimmune encephalitis, neuropsychiatric symptoms are the most common. So I made myself some notes, some behavioral changes, psychosis, seizures, memory deficits, especially short-term memory deficits if it hits the limbic system where we store our memories, abnormal movements, and altered levels of consciousness. So sometimes patients can even go into a coma from this. So that is the definition of autoimmune encephalitis. Sometimes it can be associated with a tumor. Oftentimes in NMDA encephalitis, it can be from a benign ovarian tumor that is not so benign if it's spitting out antibodies, but sometimes taking that tumor out can actually be curative, whereas there are oftentimes patients who don't have any tumors or it's not related to any sort of cancer. It just happens idiopathically, meaning we don't know exactly why it happens. It's an autoimmune response that the body is attacking the brain. And what else did I want to say about that? Oh, I will say that, NMDA encephalitis, you always learn, like we always learn in the books that you look for an ovarian teratoma. People have ovarian teratomas. I will say I've probably had like one patient out of all my NMDA patients that have had an ovarian teratoma. So you definitely have to be, I'd say in rare diseases, probably across the board, patients don't always fit into one nice little bucket. And that's why things are so hard to diagnose.
Thank you for that. Similarly, Dr. Goldschmidt, how would you define stiff person syndrome?
Yeah, stiff person syndrome, also a autoimmune disease, like most of the diseases we're talking about today. And it's characterized by generally muscle stiffness, mainly in the trunk, but also in the limbs, that causes difficulty with ambulation and walking, can have painful muscle spasms as well. On physical exam or like electromyography, you see increased muscle activation. You see, again, this like board-like stiffness in these people, and it is often associated with other autoimmune diseases, especially type 1 diabetes is the most common comorbidity with it that you see them coming together. And then there's a few different variations of stiff person syndrome as well, like a partial stiff person syndrome, or sometimes it's paraneoplastic, like related to an underlying malignancy as well.
Thank you for that. I want to take a little bit deeper dive into the diagnostic workup. I know Samira touched on that earlier, and I'm curious, Dr. Cipriani, when you mentioned some of the symptoms that people present with, are there certain symptoms that kind of clue you in that this might be what it is? And what tests are you running? And antibodies. I'm just curious what that process looks like diagnostically.
Yeah. So oftentimes, either I hear about it mostly from two ways. Number one is there's a young person in the ICU who's having refractory seizures, meaning like just, they started having seizures. They're they're happening very frequently. They're not easily treated by medications, and the person's very, very sick. That's one scenario. The other scenario is actually oftentimes from our psychiatrists who will call me and say, this patient has a really abnormal presentation of psychiatric symptoms that I think needs to be followed up, and we need to look for, they use the word organic cause. So rather than it being, in psychiatry, we don't know, and I think this will probably change, but that's a whole nother conversation, is, we don't have a lot of like biomarkers or a blood test or something when somebody's diagnosed with schizophrenia, for example. But in in psychiatry, like for example, I had a patient who was 45, I think, when she was diagnosed, and just came to the psychiatrist with these really, really severe, almost catatonic neuropsychiatric symptoms, in someone who had no history at all of psychiatric symptoms in the past. She had a very high-functioning job that she couldn't do anymore, and her psychiatrist, who was the chair of psychiatry, called my chair and said, like, we need to do something for this woman right now, and we ended up getting her diagnosed, which is a very interesting story. But so I think that's kind of the two places where I see the most referrals. Either someone's really sick in the hospital, or from a psychiatrist who says, this just doesn't fit into my diagnostic criteria. And then it sounds like you have another question before I move on to the workup. I'm just so excited
to follow up with that, because I'm thinking, seizures and these psychiatric symptoms. So when you see those two different presentations, then what? Then what tests are you running? How do you get to that diagnosis of autoimmune encephalitis?
Mm-hmm. So oftentimes patients will get an MRI of the brain, and even though it's encephalitis or inflammation of the brain, often in autoimmune encephalitis, the MRI is normal. or very minimally abnormal. It doesn't really give us, we're clinching the diagnosis with this. Then, we'll send blood work. So sometimes I'll look for evidence of systemic autoimmune diseases. So, could this patient have lupus and this be a manifestation of lupus? They can have neuropsychiatric symptoms from that. And then you can send antibodies from the blood as well as from the spinal fluid. So I remember back when I was a resident, the attendings used to tell me, well, if you sent from the blood, you shouldn't send from the CSF or vice versa because it's a waste of money. But now we actually know that, like, for some things like NMDA encephalitis, you oftentimes see it in the CSF, which is the spinal fluid, but not the blood, versus LGI1 encephalitis, which is another type. You see it in the serum or the blood and not the spinal fluid. So you really have to do what we call $1 million workup sometimes to find out what's wrong. So definitely a blood test, spinal fluid test to look for inflammation, look for specific antibodies that are related to specific types of encephalitis. And then, sometimes we have to look for tumors. Like we were talking about, sometimes it can be related to different ovarian tumors. So we'll first do a CT scan of the entire body. If it's NMDA, we'll oftentimes go to a pelvic MRI or like a transvaginal ultrasound to look for a teratoma, which is sometimes it can be microscopic, and that's, and spit off antibodies, and we can't see the actual tumor, but it's there. Sometimes we actually have to go on to do a PET scan, which is like another whole body CT with a tracer that can tell us, is there a tiny, tiny little cancer cells anywhere in the body? Oftentimes we'll do an EEG test, which is looking for seizures. So that is a brainwave test. We'll do EMG, which is a nerve and muscle test in some cases, because there are some antibody-related diseases that can cause nerve symptoms, like Casper-2 is one of them, for example. I think that was all I had on my list. But yeah, it's oftentimes the $1 million workup, like I was saying.
Wow, you really have to be a detective, it sounds like, to really be able to uncover this and try to solve the mystery. Mm-hmm. So yeah. What about stiff person syndrome?
Yeah, I'd say the diagnosis of stiff person syndrome is difficult also because it can mimic a lot of other diseases. So a lot of it is ruling out other things. So they often also get $1 million workup where we do serum blood panels looking for a variety of antibodies, including the antibodies that are known to be positive in stiff person syndrome, like the GAD65 antibody. But usually there's other things associated. We're checking also for other systemic autoimmunity as well. We often will do MRIs of the brain and the spine, to see could this be multiple sclerosis, and they're presenting just being very rigid, or something like that. EMG, the electromyography, where you check, the activity of the nerves and the muscles, can be diagnostic for stiff person syndrome. So that's definitely a big part of it. And then spinal fluid as well, because sometimes you just see these abnormal antibodies in the spinal fluid and not in the blood. And then again, in terms of kind of ruling out other diseases, if somebody's concerned, could they be stiff from Parkinson's versus stiff person? Maybe you'll do a DAT scan, which is a little bit more specific for Parkinson's disease. I've had patients sent to me for the question of stiff person syndrome, but I ended up getting genetic testing, and it showed a different genetic cause of their symptoms as opposed to stiff person syndrome. And I think because it's so rare and there's not that many people who see a ton of stiff person syndrome patients, we do a pretty exhaustive workup for a lot of these patients, mainly again to kind of rule out other things is a big part of it.
Can I ask you a question, Dr. Goldschmidt?
Yeah.
Do you have an EMGer at your institution that feels comfortable diagnosing? Because I can say that I don't, unfortunately.
Yeah, I think not anymore. I think Dr. Kincaid was doing some of that, and now she's here at Rush. So yeah, finding some, because an EMG test is a very technician-dependent test based on the person who's doing it. So I mean, if you tell them, if it's a neuromuscular trained person and you tell them specifically, this is what I am looking for, then they will be able to do that testing. But if they don't know that's necessarily the indication, then you might need to repeat a lot of these tests. We do again, it's like, okay, actually, I want you to do another EMG with this more specific question as well. So yeah, you need to find definitely the right people.
That definitely makes sense. I'm also curious too, Dr. Goldschmidt, are you also finding antibodies that could be, that are in the CSF but not the serum? Are you finding that to be true as well?
Sometimes for stiff person syndrome, you just see the GAD antibodies in the CSF, or you find a really, really low titer in the serum, and that is not convincing enough for you because low titer GAD antibodies are quite common in the general population and very, very common in people with diabetes. But if you see them in the CSF, then you're like, okay, this is probably the cause of the symptoms. Similar with sometimes you can have low level of some of these other, antibodies associated with autoimmune encephalitis. And so sometimes the titer is important. Sometimes it's important whether you see it in both the blood and the CSF. So yeah, we always like to get both for sure.
Yeah, that's fascinating to understand that, I think, from patients, because lumbar punctures are not fun. But it sounds like that they're necessary to confirm the diagnosis. I'm curious about autoimmune encephalitis and diagnostic criteria. I know for stiff person syndrome, we're currently working on getting consensus so that the doctors are using standardized diagnostic criteria. It's taking patients on average 7 years to get diagnosed with stiff person syndrome. It's brutal. These are often really difficult diagnostic odysseys. I'm curious with autoimmune encephalitis, is there standardized diagnostic criteria for autoimmune encephalitis?
There's a diagnostic criteria for like limbic encephalitis. There's a diagnostic criteria for antibody negative autoimmune encephalitis as well, which is important. Like we were talking about with the NMOSD, and if you're antibody negative, that makes the diagnostic journey a little bit more challenging. There are new antibodies that are being developed all the time. So at our institution, we send our tests to the Mayo Clinic, and one of the nice things about having a partnership with them is that you can actually talk to the people in their lab that are doing the tests. And so sometimes I call them and I'm like, these are the symptoms that this patient's having. I'm really, really concerned that this patient has an autoimmune encephalitis, and they'll actually run other tests, or they'll find something that they find interesting that hasn't really been described. But I think, the difference between stiff person versus autoimmune encephalitis is that autoimmune encephalitis is like a catch-all term for a lot of different clinical presentations. Mm-hmm. And so LGO1 patients are a lot different from NMDA patients, are a lot different from DPPX patients. And there's just, so that's where that clinical history actually is really important, because there is a lot of false positive or low positive antibody titers that people will get if they send the panels out. But what we really need to do is match the clinical symptoms to the antibody and say, do these two go together? Does this syndrome match what this antibody is doing in the majority of patients that have been described with this antibody? But also, keeping an open mind to what else could be going on. If it's not autoimmune encephalitis is another one, and being willing to deep dive into some even more rare syndromes. And then also, there are some times where, and this is what I find the hardest as a clinician, is saying, I don't know what's going on, but I will follow you over time and see what happens with your symptoms, and I will be here with you every step of the way, but I am still trying to get a grasp of what is going on, and it will present itself eventually, which I know is scary for me, but I'm not the patient. It's much more scary for the patient, I'm sure, to be told that. But so I'm interested to hear if others have thoughts about that.
I think that's so important to develop trust with patients when you don't know, to tell them you don't know, and that you're going to stick with them through the process and help find answers. Patients need to know that, and I think it really builds credibility. So
And I'm personally very open to people getting second opinions. There's a way. Being in Chicago, Mayo Clinic's pretty close, and so if people want a second opinion, I actually have access to their charts, and I can send a referral there, and things are pretty streamlined. I don't get mad when somebody goes get a second opinion, and I was telling you guys earlier when we were talking, currently I don't have any stiff person patients in my practice, so if I do think that there's a provider that there's just something I could read about stiff person in a book and know, okay, you use this to treat it. But I don't hear enough about like the day-to-day challenges that patients have and what has worked for other people. Sometimes that's where like the art of medicine comes into play, is like listening to patients over time, kind of getting that fund of knowledge in your brain about what's worked for people, what hasn't, and then giving them the advice. So if I feel like, there's somebody in the city that's better at stiff person than I am, and the patient has insurance that can see that person, that's another part of the puzzle, but that I'm happy to kind of send them along. Or even if it's, someone who's 2 hours away and I say, well, I'll be your local neurologist in case you like need anything. But if you go see this person, once a year or whatever, that's 2 hours away, I'm happy to coordinate with them. And the neuroimmunology world is very small, so we all know each other. I'm happy to work with colleagues around the Midwest.
A follow-up to the diagnosis, especially with autoimmune encephalitis, because fortunately it's becoming a lot more recognized across all of medicine, internal medicine, psychiatry, neurology, which is great because these people used to be undiagnosed and then die in psychiatric units. That being said, it's a double-edged sword because it's more recognized. We get a lot more consults for could this be an autoimmune encephalitis, and then the risk of overdiagnosis and misdiagnosis is real, and you don't want to commit patients to years of immunosuppressive therapy that can be dangerous and expensive if that's not the correct diagnosis. So a lot of our job is trying to make sure the diagnosis is correct. There's actually a very good Mayo paper from a few years ago that came out about the misdiagnosis of autoimmune encephalitis and the criteria that you should really see some objective evidence, an abnormal MRI, an abnormal ENG, abnormal spinal fluid, and not just kind of call all these people autoimmune encephalitis because they present with new onset psychiatric symptoms, because often it is new onset psychiatric disease. And then I think a lot of what we do with patients don't love, but once we explain to them why we're doing it is, I tell patients frequently in clinic that I'm going to experiment on you a little bit, because a lot of times we can tell what the disease is by how they respond to treatment, specific treatment. So for stiff person syndrome, part of the criteria is, do they respond to benzodiazepines like diazepam, And so we sometimes just have to trial that. I was like, I'm going to put you on this and see how you respond. For autoimmune encephalitis, do they respond to high-dose steroids? If they respond really well, then our suspicion is much higher for an autoimmune encephalitis. If they respond poorly, maybe it's more of a psychiatric. If they respond really well to psychiatric treatment, that changes our suspicion. So a lot of it is seeing what to make the diagnosis. Sometimes we need to treat first and see.
That's super helpful to understand. How much time do we have? I could be here all day with them. Okay. I have so many with the audience, or do I have 20 minutes with them?
I'd say try to wrap up in 20 minutes so we get to the 2 o'clock section.
Absolutely. Okay. So one more question before I move on. So is autoimmune encephalitis, is it a spectrum disorder? Are there subtypes?
Yeah, I wouldn't call it a spectrum disorder. I'd say that there are subtypes. So the different antibodies cause different syndromes and kind of clusters of symptoms. And so that's why getting that history and what your patient's going through, really, you need to link it to that antibody. So it's a little bit different than an NMOSD, where you can have, there's kind of a set of different symptoms that patients can have, and they might have one but not the other, vice versa, antibody negative or positive. In autoimmune encephalitis, it's a little different because they're very defined clinical syndromes with each antibody.
Also, the antibody can tell you where to look for cancer, because some of them are very much associated with breast cancer or lung cancer or lymphoma. So that can even guide your kind of malignancy workup as well. And like Dr. Cipriani was saying, it can be a microscopic cancer that hasn't declared itself yet. So a lot of these patients with a high suspicion, even if their initial malignancy workup was negative, we'll do PET scans every year for 5+ years, because we know that they can have a perineoplastic process 5 years before the cancer even declares itself. So it's a lot of vigilance of monitoring for malignancy.
How about stiff person syndrome? Because
It's
it's now
definitely
SPSD. There's spectrum disorder.
Yeah.
Can you speak to the subtypes?
Yeah, there are a few. There's the classic SPS, where it's kind of, this truncal and all over rigidity causes a lot of, again, gait difficulties, walking difficulties, fall, painful muscle spasms, exaggerated startle response is often seen in that. And then there is the partial stiff person syndrome, where it's more of just one limb, often a leg, that still causes a lot of, ambulation difficulties, or like stiff leg syndrome. And then there's the paraneoplastic subtype, which looks very much like the classic SPS, however, is associated with a cancer and is less likely to be GAD antibody positive. But there might be some other antibodies that could be associated with it as well. But I've definitely seen a variety of patients, whether they're presenting with like the really classic, board-like muscle spasms that are really difficult to control versus more of kind of like an insidious, like pain and some stiffness, but not quite as classic as what we read in the textbook.
Thank you. Demographic breakdown. Who are there? This is geographic, age, gender, ethnicity. For both conditions, are certain people based on the demographics more susceptible that you know of?
Yeah, definitely. I mean, for autoimmune diseases in general, often women are more effective. So for stiff person syndrome, it's like a 2 to 3 to 1 ratio, women to men, which is wild because it used to be called stiff man syndrome, which is wildly sexist. So luckily, some people still say that, yeah, but it's 2025, so I'm getting away from that. The age is also similar to a lot of autoimmune diseases, where it's like 20s to 50s onset. I don't think we have enough data to necessarily say like the racial or ethnic breakdown of it for stiff person syndrome yet. And we also know historically we have been bad at that with other diseases like multiple sclerosis because of institutionalized racism. So I think gathering more and more data, but it is in line with a lot of other autoimmune diseases like young women, is a lot of times what you think about. Obviously, it can rarely happen in peds. It can rarely happen in older people. If it's paraneoplastic, that's going to be a little bit different. It might be an older population or, not as much like the classic autoimmune.
Yeah, for autoimmune encephalitis, I'd say for every syndrome that I was talking about before has its own group of demographics. Like NMDA is the most common autoimmune encephalitis. That's usually seen more in young people or even children. Whereas LGI1 is the second most common. That's usually seen a little bit older, like in people's 60s or so. That one's like a 1-to-1 male to female ratio, whereas NMDA is a lot more female to male. So it depends on the syndrome, but the most common one affects kids and young adults most commonly.
When you say kids, how old?
I think it could be from very young, like I don't know if I've seen a toddler with it. Have you?
No, the youngest I've seen, I think, was 12 at onset. I don't know if it has to be more, if it's more common like after puberty because of some of the associated things. I'm not sure, but I've seen definitely kids with NMDA.
Mm-hmm. Yeah, older kids, I would say.
Okay. Thank you for that. One more question from me before we open this up, if there's time, Michael. I want to touch on exciting recent developments for both diseases, research or treatment. There's one comment that Dr. Miravallier, I said it right, had mentioned earlier about, we were talking about FDA-approved treatments. And I know with stiff person syndrome, we currently do not have any FDA-approved treatments. And I don't know if I heard it correctly, but I'd love to get your perspectives on this. So if you don't currently have an FDA-approved treatment, could that possibly speed up the process to get to FDA approval and ultimately get the treatment into a patient? Yeah,
I think it is complicated for a number of reasons. I think the FDA is often more motivated to approve a medication when there is nothing approved, for it. So sometimes that speeds up the process. And then I think the other side of it is recruitment for clinical trials. If there's, no FDA-approved treatment, you just have a bigger group of patients that are untreated, that are available to be enrolled in clinical trials, as opposed to right now we're talking about like in multiple sclerosis, we have almost 30 FDA-approved treatments. So it's hard to enroll patients now in clinical trials because a lot of them from an ethical perspective, we just want to start them on high efficacy therapy at diagnosis. We don't want to delay treatment or have them randomized into a trial with a low efficacy treatment, with, a 50% chance they're going to get a low efficacy treatment, or, an NMO. Now that there's FDA approved treatments, we can't do a placebo, ethically, like do a placebo-controlled trial and then allow the trials, an exclusion criteria is, they can't be on X therapy or, Y therapy or rituximab or something like that. So I think it just opens, when there isn't an FDA, it's a double-edged sword. It's not great that there's no FDA-approved treatment, but it opens up a bigger bucket of patients to be available for clinical trials. And then I think also motivates the FDA to maybe move things along a little bit faster because there isn't anything approved right now. So it's like a complicated, the more treatments we get, the better, but then it just makes it harder to recruit for trials for more new treatments because we have such good available therapies for patients that we just want to start them on and we don't want to risk, having them go on not the best treatment for them.
That's helpful to understand. Did you want to speak to that as well?
Yeah, I think as far as autoimmune encephalitis, I shared some of my frustrations up on stage earlier, but including with NMDA saying, okay, you don't want me to use this therapy, then what do you want me to use? I'm giving you all this data. Do you want your patient to do poorly? I do not understand this. And it is incredibly frustrating. I think FDA approval could help because they say it's experimental. So if there's an actual FDA approval, then they can't call it experimental anymore, which would be wonderful. So there is a trial. I know that for NMDA, there's a trial going on in Chicago through the NeuroNext network. I know Northwestern is part of it, looking at actually a drug that's approved for NMO, and to use that kind of in the acute period while somebody's in the hospital with NMDA encephalitis. So that's really, really exciting. I hope that can eventually get approved because then that'll open up the doors for treatment. But like I said, even I felt so strongly about it that I appealed it to the Illinois State Board of Insurance or whatever it is, that I said I think they did the wrong thing, thinking they would be on my side, and still disagreed, which I thought was really wild. But now that rituximab is actually generic, and there is a company that will give you free drug, it is a lot easier to use because of that. So that's kind of what I've been employing until something is FDA approved. But I think it's really great for NMDA, and I think we all know that. It's just, the powers that be aren't there yet.
That's I appreciate that, and I think what I really appreciate from both of you is fighting for your patients, really, and advocating for them, because absolutely, give them a round of applause.
Thank you.
We talk about patients advocating for themselves, but this is just an example of how physicians can help advocate for patients and how we have to work together so that we can really drive progress. So with that, I want to say thank you both. This was incredible, and if we have time for questions from the audience, that would be fantastic.
Any questions? Okay. Maybe we can get you on the mic if I borrow. This one looks a little bit longer. Let's see.
Yeah, I think that one will reach.
We're just so we have it recorded.
Okay. Yeah, my question is in regards to Dr. Goldschmidt was talking about the EMG. Is the EMG same as resetting of the brain? And if it is, or if it's not, is it a good procedure to do in a patient before being diagnosed with NMDA?
EMG has nothing to do with the brain. Actually, it just looks at the nerves and the muscles. So we use it for stiff person syndrome, which was more of a muscle disorder. We were talking about EEGs.
EEG.
Yeah, which looks at seizure activity or kind of like brain irritability, and that can be very helpful in the diagnosis of an autoimmune encephalitis, where if there's an abnormal EEG, that very much raises our suspicion that there's some sort of encephalitis or inflammation going on.
Yeah, some people will have outright seizures where they're, like in the movies, you're shaking all over, you're shaking one side, you lose consciousness, but other times patients can have, they just kind of seem confused or out of it, but when you put the EEG on, you see these abnormal brain waves, so it's really important to understand, what's going on under the surface if you're not sure what the diagnosis is yet. It can really lead you one way or another.
Got it. Thank you very much.
Any other questions? Oh, okay, please. You may have to
All right,
step
yeah, that's
forward.
fine.
Thank you.
Hi, thanks. Dr. Cipriani, earlier you mentioned you've rarely seen, or I think only one case, you've seen a teratoma in NMDA encephalitis. Do we have any idea what causes NMDA encephalitis if it's not a teratoma? And I guess to ask more broadly, autoimmune encephalitis in general, do we have any idea? Is it genetic factors, environmental factors? Do we know what causes these diseases?
Yeah, I mean, I think you could ask the same question about autoimmune disease in general across the board, but I think, there are definitely some autoimmune diseases do have genetic predispositions. I don't find that autoimmune encephalitis is one of them. So I don't think there's too much of a genetic component there. And another question that was in your write-up was like, I don't see autoimmune encephalitis necessarily linking to other autoimmune diseases as much as you see stiff person with type 1 diabetes is like very commonly associated. I would say there's not as much of that like autoimmune mix in NMDA patients. I think it probably is the immune system gets off track, starts attacking your own body, and what triggers that is a big question. I think if we don't even actually know the answer to that for multiple sclerosis. I think if we did, then we could even try to prevent it or cure it, but we just don't have that knowledge. So there probably is the immune system is in some way primed for that, and then there's some trigger that can cause the autoimmunity to continue. And I think maybe Tara will have, if you're talking about your story in the next session, you had a trigger for yours. You could share that about your situation. But where was I going? I had one other thing I was going to say about that.
Not genetic based, but
environmental trigger.
Based.
So with NMDA encephalitis, actually there is an association with HSV encephalitis. So it's an infectious encephalitis with the HSV virus, herpes simplex virus. And so afterwards, patients go home, they're looking better, and then they get, this is like a test questions for neurologists. The patient has HSV encephalitis, they go home, they're doing great, and then they come back in the hospital with, and they're in the ICU having seizures, altered level of consciousness. That's almost always NMDA. So that's like a clear viral trigger, but that's not the case for everybody. You don't always hear, we always ask, like, did you have any illness a couple of weeks beforehand? Did you have any vaccines sometimes, for other things like Guillain-Barré syndrome, for example, are associated with that. We just don't know. I think that is kind of the frontier for autoimmune disease in general, is trying to figure out exactly what triggers that.
Any other questions? Oh, we got one here.
I have a question about, I know for stiff person syndrome, they're opening a genetic, I don't want to say database, but I guess it's a genetic database where, of course, then 50% I'm sure are thinking that's great, I'll get more help, I'll help research. But the other 50% are thinking with the current political system we're in that, maybe we'll be first on the list to
go to the farm?
Yeah, go to the farm.
We know what you mean.
Yes, they get rid of the pre-existing condition.
An expensive condition, too.
I do have a question, which is for those that don't know, other conditions that we work on, NMOSD, MOGAD. NMOSD had no treatments for a very long time, but they had off-label treatments that were immune modulating. And what people have found is if you find a drug that works in one autoimmune condition, they then test it in another. So drugs that worked on MG were tried on NMOSD, worked well, so then they got an additional indication. So I'm just wondering, taking each disease in turn, stiff person syndrome, autoimmune encephalitis, what are the current standard treatments you use, and what do you see in the pipeline in development so that gives you hope that maybe there will be treatments coming soon for these conditions?
Yeah, I think there's a lot of overlap between all these neuroimmunologic conditions. It is, again, needs an expert, I think, to figure that out, because there are some medications that are used for other rheumatologic conditions like lupus or rheumatoid arthritis that can actually make neuroimmunologic conditions worse. Like Humira is one of the main ones, where Humira can kind of trigger like an MS-like. So it's not that all autoimmune treatments work for all autoimmune diseases, because the immune system is complicated and fickle. But for a lot of our neuroimmunologic diseases, I mean, a lot of us use rituximab for a lot of these B-cell therapies, especially. It makes sense mechanistically. You know, these are antibody-mediated diseases, even if we don't know what antibody it is next yet, just because we don't have that, like Mayo hasn't figured out what antibody, we can assume that it's antibody-mediated. And so things like rituximab or other B-cell therapies work well. And then, you know, they will test other like CD19 therapies that are used in NMO for some of these similar diseases. We use a lot of IVIG for stiff person syndrome and autoimmune encephalitis, plasmapheresis, and especially in the acute setting when somebody's in the hospital, to just try to clear out the antibodies from the blood. As well, for stiff person syndrome specifically, it's one of the mainstays is benzodiazepine, like muscle relaxer, diazepam, you know, Valium. And that's, again, kind of like a diagnostic point as well as a treatment point. My patients, most of them are on IVIG. Getting that approved, again, is a nightmare often for these patients, because it's not FDA approved, it's experimental. I have to talk to the insurance companies and do peer-to-peers multiple times a year for these patients, and it's like a whole rigmarole. And then treatment is delayed and the patients feel worse, which is horrible. And obviously the people you talk to in the insurance don't see the patient, you know, they don't see the patients in front of them, and they're falling and in pain, and honestly, they don't care about it. So it's a lot of fighting for treatment. And again, it's different when they're like hospitalized and seizing versus in the outpatient setting. It can be a little bit different. And then I think a big question, which hopefully the trials will help answer, is, especially for autoimmune encephalitis, like how long do you treat these patients for? And there is no consensus on that. A lot of us have our thoughts and, you know, have trained similarly and say, okay, we're going to do this for X number of years and kind of reassess. But there's no guidelines for how long you treat really any of these patients for, which is another very complicated thing. And I was just saying, I did like a peer-to-peer recently for somebody with stiff person syndrome, and the guy laughed at me because he said, you know, like, how long do you want this treatment approved for? And I said, indefinitely, you know, because this is a lifelong condition. He just laughed. It's like, we can't do that. And I was like, okay, I guess a year, and then I'll call you back in a year and just do this again, you know? So it's always this like ongoing process.
Yeah, I think she answered a lot of that question, so that was good. That's great. At least for autoimmune encephalitis, I think because NMDA is the most common one, that's the ones that have the most trials behind them. And so there's that trial, like I was talking about the Extinguish trial, they're doing at Northwestern and at a lot of the NeuroNext connected hospitals. So that's really great. And that is a B-cell depleting therapy like rituximab, which is oftentimes what we'll use as a second line. You know, the steroids, IVIG, plasma exchange in the hospital, hopefully rituximab in the hospital. And then there are other third line for people who are really sick. You know, IL-1, IL-6 drugs, complement inhibitors are being tested in small case series. CAR-T, like we were talking about for SPS, is a thought that could be helpful, that it could be helpful in autoimmune encephalitis. I would say that sometimes because people are very sick and in the ICU, often, you know, if you're on a ventilator and have a catheter, urinary catheter, there's a lot of infections that happen in the ICU. And so then you're dealing with like, I really need to immunosuppress this person, but they also have this multi-drug resistant pneumonia that I'm taking care of. So that also makes it difficult. I'll say IVIG is probably the hardest thing to get. You can't get it for free. Like there's no way to get IVIG for free. And like rituximab, you can get it usually donated by a company, but IVIG is not possible. So I often use B-cell depleting therapies, which I'd rather use IVIG because it's not immunosuppressive, but I can't because of insurance regulations. And so then moving to more immunosuppressive drugs.
We do admit patients. Sometimes we'll have to admit patients to the hospital to get them IVIG because then you bypass the whole outpatient insurance process. And it's crazy because it's obviously more expensive for insurance to cover a hospital admission than not, or for rituximab even sometimes. So we're just like, fine, I will. Broken bones. Yeah, like I will admit them to the hospital and give them IVIG inpatient. And yeah, it's wild, but we do that not infrequently, I would say, because the patient, again, they're getting worse in front of you. So you're like, what? You know, if it's going to take me weeks and weeks to get this approved, like just go to the hospital and give it to you inpatient. And then insurance will have to deal with it.
Okay, great. I think we're at time, but I just wanted to suggest to people, I think it's of interest to anybody, but there was a famous reporter who got autoimmune encephalitis, Susanna Cahalan. She wrote a book about it. They turned it into a movie. But Samira interviewed her a couple years ago, but it's on our YouTube channel. And if you're interested to hear that interview, Susanna Cahalan is very good, sharing her perspectives as a patient, someone very active in the community, navigating life with AE. So just a suggestion there. Thanks, everyone. And
Yeah, very good
Yes.
book. Yeah, I don't know. Yeah, very
and the movie's good, too. I thought the movie was pretty good.
Chloe Grace Moretz, right?
If you're more of a movie person, you can see the movie. All right, so we're going to move on now. Thank you, everyone. Warm applause for our panelists. And we're moving on now to living with AE and SPS patient